Professor Navaratnam is the President and the CEO of Cancer Care Manitoba and Professor at the Department of Internal Medicine, Reddy Faculty of Health Sciences, University of Manitoba. She is also a chair of the Canadian Association of Provincial Cancer Agencies. In her role as the President and the CEO of Cancer Care Manitoba since 2014, she has done excellent contribution to the cancer care in the region of Manitoba. Dr. Navaratnam has received her undergraduate medical training at the University of Jaffna, Sri Lanka. Subsequently, she has obtained her PhD from Department of Pharmacology, University of Manitoba, as well as internal medicine residency and subspecialty training in medical oncology at Cancer Care Manitoba and the University of Manitoba. Over to you, Dr. Navaratnam.
Thank you for this kind introduction. So good afternoon, everyone. Special guest. I thought I saw Professor Srihan, my teacher. Hello. And let me thank our Dean, Professor Surendra Kumar, and the team. I can see many of you, Dr. Geetanjali and others, for putting us such a wonderful conference and including me with those well-achieved clinicians and scientists as part of the speaker. So thank you. And it's always special to come home. And I think this is the first time I've come home to speak at this auditorium. So it's really an honor. And this auditorium was named after the first dean of medicine, Professor Hoover. He was also our teacher in biochemistry and have such a good memory of those days. So thank you for that. And I also thought when I stood up here that I see so many alumni of this faculty who are not working in this faculty or in Jaffna, but has come for this conference from other parts of the island and also from overseas, from Australia, UK, and Canada. So I really want all of you to join with me to applaud them for their commitment to this university. It's not just coming for the conference today, but the university knows the commitment throughout the years to contribute. So thank you, and I'm part of it too, but it's not a conflict of interest, but I see many of you have worked so hard for our faculty, so thank you. So my talk here, now I'll get back to that, is exploring diverse models of care and innovation for cancer control. We heard lots of talks about innovation, but what I'm trying to do today or in the next 20 minutes is to convince that innovation in the models of care is a very important one for sustainability of cancer services and cancer control. So I think in 20 minutes, I may convince you that it's not robotics that we need, but rather models of care that we have to think innovatively. So before I talk about, so I'm going to share the models of care. So many models of care all of us try, but not everything is successful. So I've chosen few models of care in my experience that has worked. So that's what I'm going to share. For me to do that, I have to kind of explain the health system very briefly. So this is the map of Canada. We have 10 provinces and territories. When it comes to health and education, it is a provincial mandate, come under provincial ministry. In other words, when you think about health, it's almost like 10 different countries in that country, because every province has their own health policies and administrations and funding and everything. Even licensing for physicians and nurses are separate. So you have to imagine that one of the provinces that I'm going to describe is a separate country for health. And so this is the Provincial Cancer Agency, has it every province, and I'm in charge of leading the Manitoba Cancer Control. So that's what Cancer Care Manitoba is. So it has, I put two things there. One is it is a cancer authority for the province. That is a legislation by the ministry. So it has lots of expectation with that. We are the one have to lead and plan and all that, and establish the standards and accountability for cancer standards. All that comes with the legislation as a cancer authority. And also, I'm very fortunate, even when the legislation changes, we kept it is a comprehensive cancer center, which I will explain what that means, that the research component is very important for a comprehensive cancer center. So I think took this opportunity of this job mainly because of this, because we have a research institute, which started as a cell biology research institute, but now recently in the last 5 years, we have expanded the scope, and which has both laboratory research, clinical research, and including health services research, which we heard a lot about implementation science and all that aspect as well. So having this research institute makes us think whatever we do, whether it is the service delivery changes or models of care or whatever we do, it has to be thought through the research lens. I mean, research is what? Is asking a question and finding the answer very methodologically. So that's the reason that I really emphasize this comprehensive cancer center, because research has to be part of everybody, I mean, I always say even the housekeeping should know what goes on in the center for us to encourage research at every level. So this is what the center I'm in charge of. And then I thought I'll share the journey, because this is a journey that many of us are going through. And I would say this is a double-sided funnel. That's the way I see it. Because we started with the training. As you heard, I started my MBBS here at the Faculty of Medicine and pursued my PhD in University of Manitoba in Canada. So, and then go through is you become a medical oncologist, and I became a clinician scientist, and focusing on this one gene of P53 for so many years, and then kind of realized that I'm more suitable to look at the system, and then moved to health services research and became an administrator. And so it's like you are staying in that narrow end of tunnel, and then now you're going to a broader outlook of life and broader outlook of research or broader outlook of health system as well. And then I have the opportunity to have some flavor of global health as well. And this is how I would say, I'm very supporter of fundamental researcher. But I think the people are increasingly recognizing the researchers the health services research and implementation science are very important as well. So now come to cancer control. That's the topic, how this service models or models of care is important for cancer. This is the burden of cancer. I hate to use the word burden, but that's what the reality is. It's regardless of which country we live in, whether it is high-income country, lower middle-income countries, cancer, this is the world death by cancer. It's just going up. So unless the sustainability is seriously considered, we cannot have cancer control anywhere in the world. This is a slide I produced in 2018 as some of the strategies for cancer control, but incorporating innovation in service delivery or models of care is one of the key factors for sustainability. So, as I said, if I convince that people to invest more into the research of models of care, I will be doing a service. So this is, most of you are familiar with, there was a cancer moonshot was declared by USA in 2016 by the vice president at the time, now is the president, John Biden. And if you look at the readings, and the goal at that time was advancing research to end cancer. But if you look at the latest report in 2024, their goals and achievements are increasing access to screening, expanding patient navigation, and cancer navigation improves equity, and better electronic health record. So from the moonshot of the thought about this, finding this cure for cancer from the genetic mutations, now people have moved because this is a necessity. So I think as researchers and scientists, we need to think about systematic way of doing this, models of care. So how we incorporated at Cancer Care Manitoba, I really want to put this here. We have one of the founders of the research institutes. Every year we do a memorial lecture at our institution. And this time we had someone, it was interesting to talk about thalassemia from Toronto. And my message for that conference we wanted to have is research cure cancer only when it reaches the patient. So we always say research cures, but it has to reach the patient. So models of care, I have used the word already without defining it. But what is models of care? It's simple. What is the care at the right time, by the right team, at the right place? And why are we thinking about it? I already talked about sustainability as a driver. The other one is accessibility. That's a huge factor why we need to think about models of care and patient experience. And this is our priority, strategic priorities of Cancer Care Manitoba for the province. And again, the models of care is part of that in sustainability. So before we go into the models of care, a few examples that I'm going to talk about, I really want to leave this that models of care cannot be just approached randomly, please. That's something we did and I failed in many occasions. So there is a plan, and we already heard about implementation science. There is lots of opportunities to learn about implementation science. So implementation has to be thought through. Another key part of that evaluation. Evaluate and continuously improve the models, and then that brings policy changes, and it goes on. So I think that's the key thing about models of care, because it is used very loosely as well in the health sector. So we need to be very careful how we approach it. So I have 4 examples, but I will only talk about 3 because of the timing. The first one is the most important one, I think. We'll talk about the Spectrum, which is a community oncology program. The second one is the improving cervical screening through self-sampling. And the last one, I will talk about some pan-Canadian work. I wouldn't go into it, but introduce the subject. So the community oncology program the goal of that is bringing high-quality care closer to home. See, the province of Manitoba, what's the Cancer Care Manitoba serves, it's a huge, Canada is geographically a vast country. And so there is an urban population of 74%, but rest is very, very rural and remote areas. So how do we serve them? So that's the principle. We wanted to bring it high quality closer to home. With that, there is also a challenge for us. There is 18% of the people are Indigenous communities. And then another 18% are visible minorities, recent immigrants have their own challenges. And importantly, 10% of population living at the low income level, at the poverty level. So that is also a challenge we need to entertain or consider it. So this community oncology program started mainly for chemotherapy first, because we didn't want everyone to come to Winnipeg, which is way at the south here. And we didn't want people to come here, but we wanted, so this is where Winnipeg is. So the people from here, they can't all come here. So that's what it started with. So we started all these dots as community cancer program. So chemotherapy will be delivered there. Again, it's a shared care model. We heard about primary care, that because the oncologists only live here or service here, but this was made possible by the partnership or shared care model with primary care physicians. We do the training and all that, but that is a shared care model that we need to explore. We cannot have 200 medical oncologists. We are short of medical oncologists. So that is one thing we all need to think about. Second one is we expanded that. So first it was chemotherapy. Then we expanded that to a navigation program to have a rapid, timely diagnosis, and also to the other spectrum of palliative care. So psychosocial oncology through navigation. So that's, it expanded from chemotherapy to timely diagnosis, to palliation, to psychosocial support. So this is a navigation program that through this, we have a navigation services to go into the community, and if somebody has suspected cancer, how could we get the rapid diagnosis as well? There is already a paper published, so I won't talk about it, the success of this. A couple of papers, in fact. And then the other one, this came up only in the last 3 years. I do visit throughout Manitoba. And when we went with the navigators, that I learned that they have not really gone to the interior, to the remote interior. So they are stopping too, because they are government. So what we did is we identified people from those remote communities, brought them to Winnipeg, to the center, and trained them. And they are the volunteers, they are the community champions. So the people who doesn't know how to get to us or to the navigator, they will reach us through these communities. And if you see it, most of them are Aboriginal, so Indigenous communities, because that's where the struggle is, mostly for us in the rural Manitoba. So how we have changed this earlier picture I showed now into a hub and spoke model. So the big circle is the hub, and from there, all these services are provided. So I could say this is what it is, but is it successful? And also, before I go further, we have also introduced this Hope and Healing program, which is a support program through this hub and spoke model. We are very fortunate to receive a large sums of donation from a philanthropy donation. And we were able to build a center for hope in a rural Manitoba. So again, this community oncology, which started for chemotherapy, now expanded to include hope and healing. And just to say, they're also being used for prevention. And what is the success? Because of the timing, I'm going to go fast. These are some of those KPIs we measure. And this is, at the end of the day, that impact the model closer to home is the survival is the same. So if you look at it, and I think, I don't want to be critical about another country, but we also do international benchmarking of cancer outcomes. So if you look at this, this is the colorectal cancer outcome in Manitoba and different provinces, different regions. So even in the remote region, seems doing very well. So is this closer to home worked? Yes, it worked. And then if you look at lung cancer, it's the same, but still that one region is slightly lower. But I was saying yesterday that if you look at UK, that our reach, the far reach northern province is doing better than UK when it comes to lung cancer outcome. So it's not to be in a boasting way I'm saying this, but to prove the point that closer to home works, the model of care works. The second one, how am I doing with time? How many more minutes? 3 minutes? Okay. So next is the improving cervical screening through human self-sampling. And I'll explain that. So this is, Pap smear is the population-based screening. This is our national target, and UC Manitoba is almost reaching the target. However, the cervical cancer incidence started going up. This is not just in Manitoba, in Canada. So, and also with COVID, the Pap smear, Pap testing went down, so we needed to create a new model. So that's what we went to this sampling, self-sampling. In other words, we send the kit, the patients do it in their own home. So we selected 3 groups. Because of the timing, I'm not going through it. It's almost like randomized way. We control group that we sent, this is the people who have not had any Pap smear done at all or in the last 5 years. And then we divided them into 3 groups, and I'm going here, it's easier. So one group received active kit. This is what you could do the test and send it back. And then the other group, do you want us to send the kit? Because we'll save some kits unnecessarily wasted. And the other one, we didn't have intervention. But as you could see it, the screening rate from 0, because this group never came, and then went to 22% and 18%. So conclusion in this study is increased screening rates up to 22% in never screened just because you changed the model of care. Decreased physician visits, and it also, because of timing, I'm not going into one of these Indigenous community, it was a really high uptake. And finally, that, this is in the province, but because I'm the chair of this one, I'm very fortunate to convince the other province we need to look at it as pan-Canadian, and the results I will be presenting at the World Cancer Congress in a few weeks, so I won't go through it. But again, the questions that we asked is, what are innovative models? Because people are doing it. but what are the innovative models that has to be implemented in Canada in different provinces, and can we scale that up, and can we make policies and all that? So that's the questions we asked. And this is the summary very quickly. I have one other slide to show. So continuous innovation of models of care is essential for cancer control. I hope I made some justice to that. Needs to be incorporated throughout the cancer continuum. And it needs to be approached systematically with continuous evaluation. And models of care keeps the patient away from the hospital. I think that's what we need to really think about it. And it improves patient experience, access, and also sustainability. And community engagement and empowerment are increasingly recognized as models of care, both in the high and the middle income countries. And I'm comparing apples and oranges, that this is Canada, the total expenditure in 2022. This is Sri Lanka, the recent report I found. I forgot to put the year, but if you look at it, the hospital expense in Canada is 24%, not including physicians, but hospital operations in Sri Lanka is 67%. So that should be an incentive to adapt to some of these models of care where you have more community and community engagement. Thank you.